You made it to the Go Commando Show with Fred Galvin. On our new mission, we contend with the naked truths of health, leadership, and overcoming adversity. Now it's time to Go Commando. Hey Commandos, welcome back to the show. This episode we have a very great guest, and you just heard his bio on the last show, and that's Dr. Brett Haake. And he is a doctor who does stem cell procedures, and you're going to be able to see him actually physically do the procedure on myself. Now, what I wanted to get across to you is I had a stem cell procedure December 2015 on my back. They injected 17 areas across my back. I have 12 herniated discs, and it was very successful. So I had recommended to my friend Dr. Brett Haake, who I've known for 9 years, as he was leaving the Navy as a physician to get into this practice, and that's exactly what he did. He's been very aggressive and successful at his practice, and he is going to be doing a procedure which you'll see on my knees. But this is the 33-day mark post-procedure, so I wanted to explain how phenomenal I feel. Now, I'm not just hyping this up, but I did not have the same range of motion in my knees, and they were filled with inflammation. So if you have these type of pains, whether it's inflammation, torn meniscus, you should really see an orthopedic surgeon after getting an MRI, and also talk to someone. We'll have throughout this show and the procedure this website for rbistemcell.com, which is Dr. Brett Haake's practice. And what you see, this may be for adult audiences just because it's some pretty aggressive procedures where you're going to see him insert some tools into my lower back to withdraw the stem cells. They're going to process it. You're going to see this entire procedure. It's really interesting and informative, but it's something that has completely been able to give me a second walk on life, literally. I used to not be able to stand for more than about 5 minutes because the inflammation in my back was so bad, and then my knees started to flare up as well. So this is something that is real. It's not any witchcraft. It's not some pill that you take. This is something that after 27 years of being in the Marines and very aggressive, demanding jobs, I had destroyed and shattered a lot of the discs in my back, caused a lot of neurological pain and symptoms, and the same thing had occurred. And you'll be able to see this procedure done on my back by Dr. Brett Haake, where he's going to take out the stem cells as well as remove from my arms some plasma that he spins to get platelet-rich plasma. Then he's going to combine those and inject it in both my knees to repair the torn meniscus. So again, great show. Stand by, and I cannot emphasize enough what this procedure has done to me. I don't do this for some hype factor, but this can really help so many Americans. And if that is you that suffer from inflammation, lack of range of motion, where you're feeling you have less mobility, contact Dr. Haake at rbistemcell.com.
My name is Dr. Haake. We are live from Regenerative Biologics Institute in Vero Beach, Florida. This is Fred Galvin. And the first part of our procedure here is we're going to extract blood from Fred for the platelet-rich plasma sample. Might as well kind of go ahead and talk about the whole procedure here. The first part is the extraction of the platelet-rich plasma. The second thing that we'll do is we'll harvest adipose tissue from Fred's flanks, and using that adipose tissue we'll extract what are called mesenchymal stem cells from Fred's adipose tissue. We'll then combine that aseptically under sterile technique with the platelet-rich plasma sample, and then under real-time ultrasound guidance we're going to place the adipose-derived stem cell. We call that a stromal vascular fraction, combined with the platelet-rich plasma, and we'll do that under real-time ultrasound guidance. We'll inject his knee joints bilaterally. So the first thing that we'll do here is the extraction of the blood for the platelet-rich plasma.
And Commandos, I've had this procedure done before on my back, where they did a similar procedure. They extracted the bone marrow from my lower, actually from my hips, and injected it 17 areas across my spine, working on the discs, the ligaments, and the facets. And now this will be done for
is that enough, Jay?
my
Pinch.
meniscus.
So what this is this is simply just venous blood. And what it has in it that we're interested in is something called platelet-rich plasma. And just very simply, all we're doing is we're taking the red cells and the white cells, and we're separating those from what is the plasma. And what we want is platelet-rich plasma, because a lot of times will say, well, when you bleed, your body naturally clots, and that's true. But what people don't realize is that the clotting factor, meaning the things that allow your body to clot, those are called clotting factors and platelets, also have a lot of pro-growth factors that are important for rebuilding tissue that's damaged. And obviously when you're bleeding, you have tissue in that area that's damaged. So that's what we're doing. We're going to combine this sample of platelet-rich plasma with the mesenchymal stem cell that we extract from Fred's adipose.
And Brett, what's the main advantages in, as far as the time, with this compared to, say, a surgery on the knee to repair or remove the meniscus?
Well, the biggest advantage, and we're going to talk about this a lot here later, but the biggest advantage here is that what you can do is you can walk into the procedure room and you can walk out of the procedure room. There's no anesthesia other than just a little local anesthesia that's required, and the downtime is almost minimal. Most of your soreness actually won't be where we inject the knee. Most of your soreness is actually going to be around the flanks where we extract the adipose tissue from, and that'll last for a couple of days. But generally speaking, you can actually drive to the procedure area and drive away from the procedure area, and obviously that's different with a surgery. There's usually a fairly decent amount of downtime, and you know obviously you can't drive to the procedure area, you can't drive away. You've got anesthesia and all those kinds of things. So that's the big advantage.
So from recovery time and being able to actually, in this case with my knee, the meniscus will actually be able to be restored, where if a regular orthopedic surgeon is going in and conducting a procedure to remove their meniscus, that meniscus is gone, and the knee is not quite the same as how you're doing it, where it's going to be able to be regenerated, correct?
Right. Well, the downtime as far as this procedure, everybody's different. So people will typically ask me, they'll say, how long am I going to be out? Or when can I start playing golf or doing whatever it is? And everybody's different. Obviously, you're a young guy, you're a healthy guy, your downtime is going to be different than somebody that's 85 that comes in here that we treat. What we tell everybody is just let your body be your guide. As far as just the regenerative properties, what we're really looking at is we want a couple of things. We want effectiveness, and we want a procedure that's safe. Right now, most of the data that we have regarding stem cell is retrospective, and what that tells us, we essentially have an interview up front, and then we look, at 3 months out, 6 months out, a year out. We look at those patients, and we have the same interview, and most of that stuff is covers things like activities of daily living and pain levels, what you were able to do before the procedure and what you were able to do after the procedure. Most of the data, there's one study in particular in Europe that looks at around a little over 1,200 patients. It's something like 1,800 joints, because some patients had more than one joint treated. But that study in particular, 90% of the patients had at least a 50% reduction in their pain scales, and with that, an improvement in their activities of daily living. About 63% of the patients had at least a 75% reduction in their pain, and that's also concurrent with their activities of daily living. And so our results, we haven't treated 1,200 patients, but our results are pretty similar, pretty consistent with those results. Not everybody has gotten better, but by and large, the majority of our patients have gotten better, and most of them have gotten significantly better. And again, the other thing is they walk into the procedure room, they walk out of the procedure room. The other big thing with that study, the one that was done in Europe, and most of the studies surrounding stem cells, is that the study in Europe, there were no major adverse events. So when we do the procedure, there's no major adverse events, and that's almost unprecedented in medicine. Almost everything that you do in medicine carries risk. Even what we're doing here today carries some risk. What we're trying to do is maximize the benefit to risk ratio. And if you have a procedure that's been performed over 1,200 times with 1,200 different patients, and you have zero major adverse events with the improvements that we're seeing, with something that we think can have some benefit and sort of help everybody moving forward. So we've got the blood sample, and at this point in time, I'll go ahead and measure you and kind of show you what we'll do in terms of the adipose extraction, and we'll go from there. Okay, so at this point of the procedure, we're basically going to provide a roadmap for Fred as far as the best place to take adipose. Now, in most patients, you can either go into the anterior abdomen around the umbilicus, or you can go to the flanks. Fred's a pretty skinny guy. He's probably skinnier and in better shape than a lot of our patients, and so I think the best thing to do for Fred is to go ahead and take the adipose from the flanks. So what I'm going to have Fred do is he's going to face the wall over here, all right? And then Fred, what you're going to do is you're going to side bend down to the right. There you go. And all I'm doing here is, if you can see here, here's a flank of adipose. So I'm just basically demarcating the borders of where I want to extract the fat. So that's where I'm going to go on the right side, and then do the same thing on the left side. There you go. So you can see it's got a border here and then kind of here. So where I'll be working is over here and over here, and then in the middle I'm going to make a little incision right here, and typically that's at about L4, the fourth lumbar vertebra. Did Jay use all the rest of those? Okay.
And Brett, what's the difference between taking it out of the flanks versus out of other parts of the body?
Not a lot of difference at all. Is this, Jason, is that sterile? That's sterile right there, correct?
All sterile over there, yeah.
Okay, perfect. Where the other sterile 4x4s? Oh, there you go. Perfect. That's perfect. The biggest reason why we're taking adipose from your flank versus other parts of your body is because when you're in good shape and you're physically fit, the fact of the matter is that the flank is typically the easiest portion of your body to take adipose from. So it's simply a matter of ease. It doesn't mean those cells are any better than or any worse than any other cells. It's just a matter of where it's most convenient to get the cells from.
And then again, if you're taking them out of the flanks versus drilling into the hips, there's less pain and less time needed for recovery.
Right. I mean, the adipose derived stem cell procedure is a little less. It's a little less painful than the bone marrow. And the other thing is that bone marrow tends to have a little bit more white cell and tends to have a little more red cell, and so the thinking is that the adipose tissue has a little bit better stem cell yield, and that's actually been demonstrated in a couple of different studies. And so we like adipose because, number one, it's more convenient for the patient, and number two, we think the yield is better. So we think we get better cells, more cells essentially from adipose than from bone marrow. Okay, we've prepped and draped aseptically, Fred. So the next part here is I'm just simply putting sterile drapes around the area that I prepped. Okay. So we're doing that right now. kid. Okay, so Fred, this is going to be a little pinch and a burn here, okay? All I'm doing is injecting local anesthetic at the side of the skin, and it's near the mark.
Okay.
So we're midline, and we're at about approximately L3, okay? So I just basically pinch the skin, okay? I pinch the skin, pull it up. I'm injecting, and you should feel a pinch and a burn, okay? Pinch and a burn. This is just a local anesthetic. This is primarily where I'm going to make a small incision to do the to get into the where the adipose tissue is at. Okay, so next I'm taking a knife and I'm making a tiny little incision. First thing I do with patients is I say, do you feel this? Make sure that the local's kicking in. So, you feel that, or do you feel just pressure?
I just feel pressure.
Okay, so it's not sharp. Okay, so that means the local's doing what we want it to do. I'm going to pinch. We're going to make a little incision. And that should be enough. Like I said, this is a tiny little incision that we make, and this is simply so that we can get access into the space that has your adipose tissue. Tiny little incision. Okay. Next is with the tumescent solution that we talked about. I'm going to draw 60 cc's of the tumescent solution. And again, the tumescent solution is 500 mLs of normal saline combined with 25 mLs of 2% lidocaine combined with 500 mics of epinephrine combined with 4 mLs of 8.4% sodium bicarb. Now sometimes the incision that we make here is not big enough, so we just make a small incision, and I think that's what we've done here, so we'll just make it. And again, the incision is typically no bigger than 2 mLs. That's what we're doing right here. We're going to make it's 1 mL right now, we're going to make it 2 mLs. There we go. That should do the trick. So that's a 2 mL incision. And all I'm doing right now is I'm spreading adipose, or excuse me, spreading tumescent solution into your subcutaneous layer. And at this part of the procedure you might feel a little poke, but as we spread the lidocaine, as we spread the tumescent solution, you'll start to feel the whole area will begin to anesthetize. And you let me know if you start feeling if it's uncomfortable. So I have 500 mLs of the tumescent. So what I do typically is I put 4 times 6. 4 times 60 is 240. So I put 4 and a quarter or so on one side, and then the same amount on the other side. So it's about 4 total of the 60 ml syringes on both sides. So this is the second one on your left side here, Fred, and I'll put 2 more on this side, and I kind of work sort of in lines. I start off, I'm at about L3, so I'll start off and flare it in a cephalad. We call that superior, so towards your head direction, okay, to about maybe T12, and then I'll work kind of in a caudad, meaning down towards your feet as we spread the tumescent solution. So kind of going from a cephalad, meaning your head, down to a caudad, meaning your feet direction. Okay, so continuing to move down. You can actually see if we can get the camera up close here, we can actually see the tumescent solution sort of get the skin here to stand up, and this is adipose tissue underneath the skin that's starting to stand up a little bit for us. And again, that just makes it easier and less painful to extract the adipose. So I've gone, what I was saying before is I've gone in this direction and then down towards your feet. We call it caudad. So from cephalad to caudad. So 3, and then this will be my 4th. You okay, Fred?
Yes.
Got a little poking? Feel a little poking?
It feels fine.
Oh, good. All right. Jason Griffiths, our stem cell scientist, he's also a owner, proprietor of Regenerative Biologics Institute. He's helping me. So what he's going to do is he's going to move our table, our stem cell table, a little bit more closer to the patient. And at this point, I'm going to move and work on your right side. So that's one, and we'll do 3 more on the right side, and then we'll typically have about 40 more mLs left, and we'll put 20 on one side, 20 on the other side. Okay, buddy?
Yep.
Now your flanks at this point should really start to feel good and numb if they haven't already. Okay? Yeah, 40 more. Is that it?
Yeah, that's it.
So I went ahead and just put all 40 on his right side, the last of the 40. So he's got approximately 280 on this side, and he's got about 220 on his left side. Okay, so now what we're going to do is this is the device that we use to extract the adipose. Okay, and what I'm going to do first is that the tumescent solution is in. The tumescent solution is in, and what I'm going to do is I'm going to break the tumescent solution up a little bit with the goal of trying to loosen the adipose tissue or separate the adipose tissue from the muscle. And so that's what we're doing right here. Now this happens fairly often, so we just grab another towel and we put it on the left flank. We'll just put this right here. And we'll go about our business. So this is right now all we're doing is we're getting the adipose tissue to stand up. Okay, so what we're doing is we're essentially just breaking up the adipose tissue and allowing the tumescent solution to do its job. And we're working obviously right now on Fred's right side. Essentially this is his right lumbar flank, and this is where you have a good solid sample of adipose tissue. We have patients of all different ages, shapes, and sizes, and so the flank comes in particularly handy when you have former or current professional athletes, college athletes, CrossFit athletes, these types of people that tend not to have a high percentage of body fat. The flank a lot of times is really the only place where you can get a consistent large sample of fat. So what I just did is I used the syringe. There's a device within this syringe that essentially creates suction, and I'm just kind of going back and forth on Fred's right flank so that I can extract the adipose tissue from the right flank, and I'm just moving back and forth with my device, using kind of consistent motion back and forth with a device here that creates suction, so that I can move the adipose from the flank into the 60 cc syringe. You feeling that any pain at all, Fred?
No, I don't feel any pain.
Good. So you can see Fred's first yield is not exactly robust. Not to worry. Not to worry. That's why we work in the flank. And so a lot of times your second, third, fourth yields are the ones that are more robust in terms of the yield of the adipose. But we'll get there and we'll get what we need, and it won't be a problem. So this is actually a nice problem to have, Fred. So we'll talk about with Dr. Haake later on tonight, the Whole30 lifestyle modification, what that does to your stores of fat. You okay?
Yep.
You got about 7 cc's.
And how many you're shooting for?
Anywhere from 60 to 100.
And then once that local wears off, what types of pain do you think, and how long should that be?
The biggest thing is it's sore. So it's not sharp pain. It's not excruciating pain. It feels sore. It feels, like we were poking around back there a little bit, and that typically will last for several days, and it gradually goes away without any issue. But
Somebody could get on a plane and travel
without question, without any problems at all. And like I said, everybody's different. We've had 85-year-olds who like playing pickleball. That's a game that's popular here in Florida. And we had one guy that basically started playing pickleball within a couple of days. He felt so good. And we have other people that say, well, I was a little sore. I wanted to take it easy for a week, and that's not a problem. We don't really have any specific recommendations. We don't say, well, you got to stay off it for 2 weeks, or you can go back after a week. We kind of tell you to let your body be your guide, and that's because we're treating kind of a whole slew of different patients with different age groups, different pain levels, different injuries, etc.
And so some people could go back to work within a day or two.
Without question. Without question. If you wanted to go back to work within a day or two, you could.
And we've had people get treated in the morning and go back to work in the afternoon.
Wow.
Now, Fred's tolerated this procedure very well, but I'd say most of our patients tolerate the procedure exactly like this. They simply just relax. They don't need any anesthesia other than the local anesthesia that I described before, and they're able to talk to you throughout the entire procedure. So don't think that just because Fred's a grunt that he's tolerating this better than the average person. This everybody tends to do really well with this kind of procedure. It's just very simple, tiny incision that we talked about, and away we go.
There's not really any large scar that's hardly even visible, is there?
Not at all. I mean, we can get a close-up of where I'm working, but like I said, it's where I'm working right now is approximately 2 millimeters. A little incision. It's probably 2 millimeters wide, and it's probably maybe 2 millimeters deep. And I made the incision, and that's where I'm working to get into the fat layer. And that's that incision typically will take maybe, it does not even need a stitch, and it might take about a week to heal completely. The biggest inconvenience that patients note is that over the next 3 to 4 days, you'll notice continued leaking of the tumescent solution out of the incision site, and that's not typically a big inconvenience. So this is oftentimes patients will come to us and they'll say, hey, I'm having pain in both joints. In your case, it's your knees, but I have more pain in one knee than in the other knee. You okay?
Yeah, it's sharp.
Okay. We'll move. So Fred just mentioned it's sharp. As we move cephalad, this just means that we were working in an area where there's not a lot of local anesthesia. So I just simply move in a more caudal direction, and so I can work in the area that we have the local anesthesia. But getting back to the joint situation, if patients have adipose tissue that's easily extractable, and we'll say, yeah, no problem, we'll do both joints. But sometimes, like the case is with you, it's difficult to get a big yield of adipose. So sometimes we'll say, well, would you like us to just treat the joint that's more painful now, or that's more diseased now, and then we'll go back for the other joint later? Or do you want us to kind of dilute our sample a little bit and treat both joints? Either way, it's not a problem. And again, the majority of our patients that we've been treating get better. And typically the most common injury or the most common disease process that we treat is osteoarthritis. But we do treat, in your case, Fred, you've got your MRI showed a medial meniscal tear at the lateral horn, or excuse me, you have basically a tear of your medial meniscus, and not your lateral horn, your medial meniscus, and that's a common injury that we treat, and patients do better.
What's going on in the other knee?
Similar pain. That was the first developed on the left side, and that's what drove me to get the MRI and pain, and then same exact pain place on the right side.
So this is a good yield right here, Jason.
Now the actual stem cell, can you describe a little bit about how the stem cells and DNA and how it can be taken from one area of your body and used in another and regenerate the tissues?
Absolutely. So, and I'm going to let Jason talk about this a little bit more, but what we do is, like I mentioned before, we sterilely draw the venous blood, and then from the venous blood we separate out the red cells and the white cells, and we get a fraction of that blood called platelet-rich plasma. So then after that, we're doing what we're doing here, and we basically take your adipose tissue, and from your adipose tissue we separate out what are called mesenchymal stem cells. The technical term for that is called stromal vascular fraction, but they're basically mesenchymal stem cells, and these are stem cells that typically will regenerate tissue. And so what we do at the level of the joint is we combine the mesenchymal stem cells with what's called platelet-rich plasma. We good, or we need one more?
We can do one more.
I think we should, because that was the best yield yet. So we combine the mesenchymal stem cells with platelet-rich plasma, and that platelet-rich plasma will form a scaffolding which allows the mesenchymal stem cells to proliferate and to flourish. And so why we use adipose, about 20 years ago, a guy that Jason actually works with had worked with in the past, looked at adipose-derived stem cells and found that there's actually a very rich supply of stem cells in adipose tissue. And so, like I said before, a lot of the studies that we've looked at comparing adipose to other forms of stem cells show that you get a big yield of stem cell, in particular mesenchymal stem cells from the adipose tissue. And we combine that, like I said, with the platelet-rich plasma so that the stem cell has a scaffolding, if you will, a platform to grow and proliferate at the level of the joint. So the last yield here was a nice yield, was a big yield. It looks like we're getting a lot of adipose, so I'm going to keep working on your left, even though we've been working on your left probably a little more at this point than your right. The yield here on the left is pretty robust, so I'm going to keep working over here. And it looks like our sample's starting to really build up. We're at about 40 cc's of adipose now, so we're in good shape.
Sort of like the fishing we've been doing over the last few days. You got to stick with it and have some patience.
Yeah. We had a nice sheep's head Sunday night. We caught one here on the east coast of Florida. Fred caught one with his buddy over on the west coast. People have been tearing some sheep's head up across the state of Florida, and then Fred almost got a slot snook yesterday during the afternoon. It was a little short, but it was almost 28 inches. Had it been 20 inches, that would have been 28 inches. That would have been dinner. But he almost got a slot snook. So we've been having some fun. So Jason, why don't you talk to the audience a little bit more about your experience with bone marrow, your experience with adipose, and being a stem cell scientist, why you got into adipose versus bone marrow. And we'll talk about this more in depth later on, but I think this is important for the audience to understand.
Yeah, we started in the early 2000s, and we have always been looking for the optimal source of stem cells in the body. When we started in the early 2000s, we were using muscle-derived stem cells from a patient's thigh muscle. So we would take a chunk of muscle from their thigh, and then we would bring it to our laboratory. And since there's not a lot of stem cells in the muscle tissue, we actually had to grow those cells out for 3 to 4 weeks. So we've come a long way and discovered that the adipose tissue is a much richer source of stem cells. And we can get that same amount that we used to get in 3 to 4 weeks, we can get here at the point of care in about 45 minutes. But yes, we have worked with a variety of stem cell types over the years, including the muscle stem cells, bone marrow stem cells, but adipose stem cells are kind of the new kids on the block, but we really like them because they can be obtained in a minimally invasive procedure, and it turns out to be the body's richest source of stem cells, so we can get a lot of them in a very short amount of time.
So it's basically a double victory, right? You have a minimally invasive procedure. It's much less painful than bone marrow extraction, and it's as Jason was explaining before. Now they were using thigh muscle. This is back in the early 2000s with the company, and they had permission, so they were using thigh muscle. They would culture expand the muscle, and then they would implant that on the anterior aspect of the patient's left ventricle. That's the part of the heart that pumps blood to the entire body. That was what they were doing in the early 2000s. But what Jason's partner at the time and what Jason discovered was that they could actually get as rich a source of stem cell by simply extracting adipose and doing that point of care, meaning you didn't even have to culture expand. They were getting as rich a yield of stem cell as they were previously when they'd extract stem cell from the thigh muscle and culture expand them over a period of 3 to 4 weeks. And so, like I said before, if you're a stem cell clinic like we are right here, you're not actually allowed to culture expand anything. So even if we wanted to, we couldn't. So that makes us, we're forced to rely on doing point of care, and we need to have a good rich yield right at the point of care, and that's why we do adipose. And that's just lucky that we're also able to do it in a way that's minimally invasive and almost painless to the patient.
And so for those that maybe have had concerns regarding stem cells from another body or from a fetus, this is not anything that you guys are doing.
The thing is that I think it might have been 2007 maybe. Basically, we realized that we don't have to we can get a rich yield of stem cell, adult stem cells, from the individual that we're working on, and we don't have to worry at all about the ethical concerns, and that's something I wouldn't do anyways, but the ethical concerns from extracting stem cells from a fetus or any other type of mechanism. And again, as it stands right now, unless you have permission to do a study and you've got research permission, you actually cannot use stem cells from one individual and implant them in another individual unless you're doing something that like a transplant or something that you've received research permission. If you're just a stem cell clinic, you have to do point of care. So we can't culture expand, and we can't use stem cells from someone else and then put them in somebody here. We essentially extract your own stem cells, we separate them from the adipose, combine them with platelet-rich plasma, and then over a period of about an hour, that takes about an hour to prepare that sample, we call that a pellet. We'll place that into whatever joint you're having pain or the disease process, and we do that under real-time ultrasound guidance. So it's all safe, and it's all minimally invasive, and it's like we talked about before, very convenient, not only in terms of the pain process or the painlessness of it, but also the fact that you can walk into the procedure room and you can walk out of the procedure room. Okay. So we're done with the adipose extraction. At this point, we're going to prepare we're going to separate out the mesenchymal stem cell from the adipose sample, and we'll combine that with the platelet-rich plasma.
Hey, Commandos, I'm here with Brian, and we have just extracted the blood, and he is going to put it into the centrifuge, and I'm going to have him describe what he's doing to both the blood and the stem cells in this next procedure.
Yeah, so I'm the stem cell scientist, and once Dr. Haake gets the tissue sample, the adipose tissue sample, I then take it, and the first step is to wash and clean the tissue to remove any of the lidocaine solution and also remove some of the red blood cells. And then we digest the tissue with a reagent. So within the adipose tissue, there's lots of cells, a variety of cells. There's adipocytes, which are the actual fat cells. There's connective tissue, and then there's a bunch of stem cells within all that tissue. There's mesenchymal stem cells, endothelial progenitor cells, pericytes. And so what the reagent does is breaks down the connective tissue so that all the cells begin to float in a centrifuge tube. And then what we do is we centrifuge it, and you can see that at the bottom here there's a big pellet. So all of the regenerative stem cells, which is also called the stromal vascular fraction, pellets at the bottom of the centrifuge tube. And then we have some of the wash solution, and then all the cells that we don't want, and the lipids, they're all up here. The connective tissue, the actual adipocytes, those all float. So everything we want, pellets at the bottom. So, and this pellet has mesenchymal stem cells, endothelial progenitor cells, hematopoietic stem cells, and a nice stem cell composition that can stimulate healing within the joint. And then the other thing that we do is after Dr. Haake gives me the blood sample, we spin the blood down to concentrate the platelet-rich plasma. So within the blood, you have red blood cells, you have white blood cells, you have platelets, and you have plasma. So what we do is we process the blood to get rid of all the red blood cells, which pellet at the bottom of the centrifuge tube, as you can see here. At the bottom there, that's all red blood cells. We get rid of those, and then just above that is what we call the platelet-rich plasma layer. That's where all the concentrated platelets go. And then right above that is what we call the platelet-poor plasma. Some people use the platelet-poor plasma, but we're mostly interested in the platelet-rich plasma, which has all those platelets in it. Those platelets have a lot of growth factors and proteins in it that help the stem cells grow within the joint. It also creates a biological scaffold for the cells to be held there within the joint. And basically, these two things, stem cells and platelets, are your body's natural healing ability. We're just super concentrating it and placing it exactly where it needs to be.
So right now we're preparing the stem cell pellet, and my assistant Jason is preparing that and combining that with the platelet-rich plasma. So that process typically takes about an hour, and we've already demonstrated the adipose extraction with the tumescent solution, and that followed just the blood draw to prepare the platelet-rich plasma. But right now, all I'm doing is just mapping out Fred's knee joint. I've got an ultrasound probe right here. You don't have to use the ultrasound, but this just makes it more exact. And essentially what I'm looking for is I'm looking for the tibial plateau, and I'm looking for his patella. And in between those two, the tibial plateau and the patella is the patella tendon, and I'm looking for the patella tendon, and I'm going to go right underneath the patella tendon to place the stem cell pellet, because that's where the knee joint is at. So this is the left side, and I've just marked the spot, the spot where I'm going to place the injection on the left knee, and then I'm going to do the same thing for the right side, for Fred's right knee. So we're doing the same exact thing here for the right side. So I can kind of have an idea. Here's his patella, here's his tibial plateau, here's where I'm feeling the patella tendon. And I'm going to place the ultrasound probe directly over that location. I can see his tibial plateau, I can see his patella. I'm going to go right in the middle, and I'm going to mark where I'm going to go here with my pen. So that should be a bullseye. So that's that. So now we're just waiting on the preparation of the stromal vascular fraction, or the stem cell pellet, and like I said, we'll combine that with platelet-rich plasma, and we'll go from there. This part of the procedure, after the preparation, the injection part of the procedure, will take about 5 minutes max. So the next part of the procedure is the injection of the stem cell pellet combined with the platelet-rich plasma into Fred's knee joint. Okay, so we have the pellet here. This is one of the pellets, Jason? Okay, so we have the pellet here. The first thing, we've already mapped out the knee joint with the ultrasound, okay? The next thing that I'm going to do is prep and drape the area that I'm working, Fred's left knee joint, with aseptic technique, okay? And I'm just cleaning that area off with an alcohol prep. Next thing I'm going to do is I'm going to apply a little local anesthetic to the site, and this is just lidocaine, okay? And this is just anesthetizes the subcutaneous tissue. It's important to remember I'm not putting any lidocaine in the joint. Pinch and a burn. I'm not putting any lidocaine in the joint because I don't want, there's some evidence that suggests that the lidocaine can actually have an adverse effect on the stem cell. So I'm just trying to put it here in the subcutaneous, the level of the skin, to kind of take a little of the pain away. So we do that, and then the next part is the actual injection. And this is important to remember, that I'm injecting a finite amount of stem cell in a finite joint. And so part of this, the part that may hurt, okay, pressure, is just you may have a little bit of pressure. So we're just injecting. We're right in the area where we need to be, and I'm just going to slowly inject. And you do this slowly because, again, it's not so much a sharp pain as much as it is a lot of pressure buildup, because, again, I'm putting a finite amount of fluid in a finite space. And so as we do this, Fred may actually feel a little more pressure as we get to the end of the stem cell injection. And I don't know if the audience had a chance to see, but this is approximately 6 to 7 cc's of platelet-rich plasma combined with the stromal vascular fraction, the stem cell pellet. We're almost done. We're getting right to the end of it, and that's it. We're done. That's injection number 1. Okay. And we're going to do the second part now. We're going to work on Fred's left knee. Before we do that, put a little Band-Aid on his right knee. So Fred, tell the audience, was that kind of painful or incredibly painful or just
like you said, Brett? It was like a pinch. Then after that, you could feel this platelets and stem cells going in, but there was no pain necessarily.
Good. Perfect. We're going to just get that area cleaned up. And obviously to do the other side, everything's fresh. We use all new needles, obviously a new stem cell pellet. And I'll show the audience. So we're just going to put a Band-Aid here on the right.
And
so I have 2 here.
Brett, there's been some concern with some folks that may go to different practices on, the amount, the concentration, how pure this is. So that's why we're filming it. And if you're watching this, or especially if you're listening to this, you really do need to go to the Go Commando Show YouTube page so you can watch the whole procedure. This is what goes on. There's nobody going to a different room. It's all done withdrawn from your arm like you saw, or from, in my case, the flanks. Then it's harvested and spun in a centrifuge to get down to those platelet-rich plasma in the stem cells. So there is no question on, how much, or is this authentic, or is somebody just...
Well, what we, I think that there's still questions regarding stem cell. And what we invite anybody to do, whether you're, from a lab or you're inquiring, is to come here and actually measure our stem cell yield from the adipose, because we're convinced that this is where you get the greatest number of stem cells, the richest supply of stem cells, in conjunction with not having the white cells that you get from bone marrow. And again, those are the things that have a tendency to be catabolic, meaning they can break your tissue down. We don't want those. We want the things that are pro-growth. And so everything we do, like you were saying, we get the platelet-rich plasma from your venous blood. We get the adipose-derived stem cells, in your case, from the flank. And everything that we do is point of care. We then harvest what we need via a series of enzymatic reactions that we do in the lab. We combine the platelet-rich plasma with the stem cell pellet, and then right here at the point of care, we inject your knee. So
and Jason showed us that step previously.
Here's the lidocaine, and again, I just use it at the level of the skin. We've already got the area that we want to work marked off, okay? And in this case, this is Fred's left knee, okay? I'm going to inject a little bit of lidocaine at the skin to just sort of take some of the pain away. Okay, a little pinch and a burn. So there's the lidocaine. But again, I don't want to put that into the joint. Here's my stem cell pellet that we just prepared. Okay, and I'm going to go into the joint. Pressure. All right, now I'm in the joint. And again, I'm just going to inject slowly. And in Fred's case, he's got a tear of his medial meniscus on the left. And so what we're doing here is we're going a little bit medial, but we're still essentially right in the joint, in the knee joint.
And can you describe how that actually helps the meniscus recover and repair?
Basically what we're doing is we're putting tissue, we're putting mesenchymal stem cells and platelet-rich plasma at that level. And the mesen, for those of, in case we haven't, there's the needle right there. The mesenchymal stem cells are essentially exactly that. They're stem cells that essentially code for connective tissue. And so by putting them in that area, they will actually begin to form knee tissue. And so we combine that with the platelet-rich plasma. And the other thing is that what we found is that whenever you inject a stem cell, whether you place it into the IV or you place it, the stem cell will actually migrate to an area of inflammation and begin to repair that area of inflammation. So in this case, it's working at the level of the knee, and it's going to repair. It's going to regenerate the tissue at the level of the knee.
So, Brett, we just finished the procedure. My knees feel fine right now. There's no adverse reaction. And as the viewers saw, this is entirely from, the blood out of my veins, the stem cells out of my back that Jason processed. It's all done right here in the same room. There's nothing phony or fake about it. And I look forward to giving you all an update here in the near future in about a week, and we'll put this whole podcast together so you can hear from me exactly how it's making me feel. But Brett, if you would explain exactly to the listeners who may have heard a lot about stem cells, you just injected those stem cells into both of my knees where I've had some damage to the meniscus. Many people have these. And what are those stem cells in the platelet-rich plasma? What's it actually doing in my body right now?
Yeah, so the stem cells are kind of interesting because there's been a number of different studies that have demonstrated that if you actually inject them into the body, that they'll actually migrate towards an area of inflammation and begin to repair that particular area. And so what we did in your case and what we do in most of our patients' cases is, again, we extracted your blood to get what we call platelet-rich plasma, and then we extracted adipose tissue to then get what we call the stromal vascular fraction, which are essentially mesenchymal stem cells. We combine that with the platelet-rich plasma, and then we inject it at the level of the joint. So what the mesenchymal stem cells are going to do at the level of your knee joint is we call this term plasticity, meaning they're influenced by the environment that they're in. So if they're in a knee joint, they begin to generate knee tissue, and they have a very anti-inflammatory, pro-growth effect on the area that they're in, and in your case, the knee. And so our hope is, and in fact our results have been, that the overwhelming majority of the time that patients have inflammation or they have osteoarthritis, that they achieve significant improvement. And I think the key to remember is it's just a term called plasticity, and that just means that the stem cell is your body's essentially genetically programmed to heal itself, and it does this through the use of stem cells. And the term is plasticity, meaning they're influenced by the particular environment that they're in. And in your case, it's the knee joint.
Yes. And so for a lot of listeners, I had one orthopedic surgeon back where I'm from in the Midwest explain, our bodies, if you could compare it to having basically like a 100,000 mile warranty, and you can drive those 100,000 miles in your first 30 or 40 years, or they could last a lifetime. But if you have done some kind of repetitive activity, whether it's farming, whether it's sports, whether it's military, something that's repetitive and wearing out a joint, whether that's your wrist, your shoulder. And I've had this procedure done on both my back approximately 2 years ago, and now both my knees. And, we are hoping the same thing that happened in my back, it is able to really restore those damaged areas, just like Dr. Haake has mentioned. My days in the Marine Infantry, Force Reconnaissance, Marine Special Operations, I'm not the typical chest beater. I'm very mild-mannered, but it's caused over those years a ton of wear and tear and damage. Those 100,000 miles have been gone a long time ago, and this was, the doctors told me, I had an option of either knee surgery or talking to a friend of mine who I've known for 9 years, Dr. Brett Haake with RBI, Regenerative Biologics Institute at RBI.com, came down and took place here in just one afternoon. And I'll be walking out. Just had the procedure. I can walk without pain right now. So it's a very incredible testimony. Brett, if you would talk briefly on the types of joints that you treat and can treat here
Sure.
at
Yeah,
Regenerative
absolutely.
Biologics Institute.
Essentially any joint. Fred's mentioned that he had the back procedure a couple of years ago. We also do backs. Knees are probably our most common joint, but we've also treated wrists, elbows, shoulders, hips, and ankles. And so essentially any joint, and in conjunction with backs, everything that we do is, every joint that we do is under real-time ultrasound guidance. In the case of backs, obviously we do it fluoroscopically guided to make sure that we're in the epidural space or we're in the paravertebral space. Just to sort of add on, though, to what Fred was talking about before, what he's talking about is he's able to walk into the procedure room and he's able to walk out of the procedure room. The overwhelming majority of our patients have gotten better, and I think the proof's in the pudding. I think obviously we just finished the procedure, so from a long-term standpoint, it's obviously too early to tell. But what we would like to do is here in a month do another interview of Fred and see how he's feeling, with the expectation that his knees will be in a better position then than they are right now. But the first part of the procedure has been completed, and again, like he was saying before, no surgery, there's no anesthesia involved. He walks into the procedure room and then walks out of the procedure room, and that, I think, in and of itself is a victory. But I think we'll talk a little bit more about some of the studies with stem cell and about some of the results that we've gotten, not just here, but across the world in places like Europe, and different places. Some of the safety profile, and then some of the results in terms of not just pain levels, but also activities of daily living. So that's interesting as well. And then we'll compare that with Fred's result and what happens with him a month from now and then 6 months out. And so hopefully, again, the proof is typically within the pudding. So we look forward to that.
And tonight we'll also answer the question on where Brett and Jason see their practice going into the future. One of the things I also wanted to include about this is there's a lot of procedures that, and how I met Brett. He was a naval officer, a doctor that I met when I was stationed overseas, and we're both stationed overseas. And that's where we met. We developed a friendship that's lasted over 9 years. And, him being in Navy medicine, me being in the Marine Corps, which is a department of the Navy. It's the men's department. And but we relied upon the Navy to get our medicine. And actually, where we both left the service, and I retired out of there on the East Coast, where Brett was a doctor at a hospital, they did some procedures that we'll talk about more, such as epidural injections into my back to relieve some of that pain. This is before I ever left the military and knew about stem cells. They did that 6 times. I've had that explained, and Brett will talk about that as far as what that's actually doing to your muscles and the pros and cons of that. And then they also did a radio frequency ablation, deadening nerves that were very painful in my back. And there are definite pros and cons about those pains. So, individuals that have these pains, whether it's neck, shoulder, wrist, knee, back, and I've had those all, and not all those procedures that I had explained, this is what we have available to you, because of Navy medicine, or, in some individuals' case, that's what their insurance plan will, pay for. It is very important that you understand that, those may have a much longer recovery time. They may actually deteriorate muscle. And I don't know if you want to address any of those at this point, Brett, or...
Well, I think in your case, again, I think everything that we look at in medicine is from a benefit risk standpoint. I will say that the majority of the patients, or a lot of the patients that we treated in the pain clinic and that we treat in the military, are younger, active duty guys. A lot of guys are obviously very active. Certainly, especially in Southeast Virginia, you have the SEAL teams and various other units that are highly active and highly athletic. I think the thing to remember is that you've got lots of inflammation. A lot of these patients develop herniated discs and what we call foraminal narrowing, where you have impingement of the nerve root as it exits foramen. As it exits the foramen, it gets impingement, and so the steroid injection is actually beneficial for that. But I think and a lot of times it's a single shot. Patients get better and they move on. But a lot of times in these chronic patients that are retired, patients that are maybe still active but starting to get older, you do this over and over and over again. And the steroid is called a corticosteroid as opposed to an anabolic steroid. A corticosteroid is something that breaks tissue down. It has what we call a catabolic effect. And so in the long term, it can actually have some deleterious effects at the level of the injection, especially if you're doing it over and over and over again. So again, there's pros and cons. It's not what we do here. I'm not against it. I'm not saying it's a bad thing, but I think it's like anything else. It's something that you have to understand the risk, understand the benefit, and the benefit of what we're doing here, and we'll talk more about this later, but the benefit of what we're doing here is there's almost zero major adverse event, and the majority of our patients are getting better. And we know that what we're putting into your area of inflammation, whether it be your back or your knee joint, in Fred's case, has a pro-growth anabolic effect, and ultimately is good for the tissue that we're in the joint that we're treating. So that's the advantage, and again, we look forward to kind of elaborating on that a little bit more.
Thanks, Commandos, and again, stay tuned. We have other great podcasts. I will be giving an update as far as when this is released. You will know exactly how it's feeling after a month, and they have actually offered special pricing for active duty, military, law enforcement, and Gold Star families who have had a loved one who was killed in action. So they will definitely are very friendly to those who have made those types of sacrifices for our nation and are currently serving on the front lines. And we would definitely appreciate you for doing that. And he's definitely a veteran, served as a naval officer, actually went and deployed to combat in Afghanistan as a medical officer, and has served our country very faithfully. Thank you very much for your service.
Well, thank you. Thank you for having us. And just to reiterate what Fred says, we do have all kinds of packages, but in particular for the first responders, for our active duty, and also retired military, as well as police officers, firefighters. We have special packages. Also, in conjunction with that, we're a national brand. We're here in Vero Beach, Florida, but we treat patients from all over the country, and we actually have programs and packages where we'll fly you in, we'll put you up at certain hotels. In our case, Vero Beach Resort and Spa. We'll have you stay there and then come over and get your treatment and then fly you back out. So these are all things to take into consideration. And again, we'll elaborate a little bit more on this later on tonight.
Yeah.
All right.
It's a great place to have it done down here in southern and South Florida. Fly in and out and get your body healed. So thank you very much, Commandos. Look forward to giving you an update here soon.
To all my fellow grunts out there who in your youth felt it was your duty to protect us, I salute you. And thanks to the listeners of the Go Commando Show who labor on the farm, who are sweating on the construction site, putting forth your very best at the office. You are making a difference. Support the Go Commando Show in our pursuit of bringing you the highest quality professionals. Infiltrate the website at gocommandoshow.com, where you can view all of the podcasts and arm your team with incredible deals on health supplements, commando clothing, and equipment. Every time that you get a good deal, it supports the show. What deals? When you purchase anything from the website, Amazon, healthcare supplements, you're covering our six. And to the ladies on the team, when you outfit yourself in the super sexy threads from Naked Zebra, and yes, I'm talking about in a fuego, you are firing the sniper shot for our commandos. How else can you support? It's simple. You smash the follow and subscribe buttons on our social media. That is how you support us bringing great guests to talk about serious subjects, not the mainstream media's fake news. So thank you, and until our next show, stay in the attack and go Commando.